Welcome to the Sacriva Diagnostics Clinical Education recording entitled Antiplatelet Therapy Testing in Clinical Practice. This presentation was given at a workshop at the 2016 Society for Blood Management meeting in Grand Rapids, Michigan by Dr. Majed Refaii. Dr. Refaii is an associate professor of pathology and laboratory medicine at the University of Rochester, as well as the director of the Thrombosis and Hemostasis Laboratory. We are pleased to provide this presentation to you via our website and hope you will benefit from listening to Dr. Refaai's perspective on the clinical utilization of the VerifyNow system.
Okay, so I'm going to talk a little bit about the clinical utilization of VerifyNow system. These are my disclosures. I don't have a lot, just whatever I could be able to fit in one slide. But I have to put them all because I don't know who's here, who's listening to me, where is this going to be ended up going to. So if I said none, I'll be lying. The objective of my presentation today is I'm going to talk about a case just to present it's kind of like where we use VerifyNow the most. Explain the platelet role in normal hemostasis and why do we care about platelet reactivity or platelet function, and why we choose VerifyNow. Then I'll give you a few minutes at the end for questions. So a 66-year-old male presents with a history of chronic heart failure and LVAD implementation for his third time. So this is his third LVAD. Admitted to the hospital due to this discomfort and chest pain, shortness of breath. At the end of the workup, revealed that he has clotted his third LVAD. His past medical history was significant for two previous clotting of his LVADs. Patient was on 81 milligram aspirin, daily aspirin, 70 milligram daily Plavix, and 5 milligram Coumadin at that time. So, normal hemostasis. In order for you to have a normal hemostasis, as we did here to the coagulation talk this morning, I'm just going to briefly touch base on these. You have to have it's a component of four major events that's needed to have a normal hemostasis, and you have to have them all normal. First of all, you need your vascular constriction, so you need a normal vascular in order for it to limit the blood flow and to reduce bleeding, even from a paper cut. You need a functional platelet, because platelet will initiate the platelet block, what we call it, or platelet clot. Then you need coagulation factors, normal coagulation factors, and function and quantity to form the fibrin clot. And then finally, at the end, a few days later, you don't need this clot to stay with you for the rest of your life. You definitely need a system to lyse this clot. Otherwise, from a paper clot, you could clot the whole arm, So you don't need this. So basically, there's a fibrinolytic system will kick in later on. And within a week or two, you cannot even tell where was the paper cut was, okay? So, as we said, so platelets, first of all, bind to von Willebrand factor, which bind also to the collagen surrounding the blood vessels. We're going to see in the next slide, we're going to have a cartoon explaining all of this. Along with von Willebrand factor, they initiate the first clot, what we call platelet block, and both of these together, they form the primary hemostasis. Now, platelet membrane is needed as well, in addition to whatever platelets contain inside their granules, to provide the adequate factors and adequate phospholipid layer needed to form the secondary hemostasis, which is the activation of coagulation factors. Now, if this is a blood vessel, and as you can see this over here, the red blood cells, platelets, coagulation factors or von Willebrand, and this is all the plasma with endothelial cells surrounding the vessel. At the time of injury, we'll lose some blood, and von Willebrand start binding first to the collagen surrounding the blood vessel. Platelets very close to the von Willebrand because they usually run on the sides of the walls. They always because they are very small and they are small in size and numbers. Red blood cells will push them to the sides, which is good because we need the platelets to be on the sides. So they will get in touch with the injured place and they will bind to von Willebrand and bind to the collagen. They on themselves they have receptor for the collagen, and they do have receptor to bind to von Willebrand. Once this happens, then they'll get activated. When they get activated, they get different shape and they release their granules. The different shape is good because they're gonna close the hole. This is what we call agglutination. When they agglutinate, they spread. Okay, it's better to close the hole with smacked platelets than just normal platelets. Normal platelets is imagined like an egg. You won't be able to close a hole with as much eggs as they can give you. But when you smash this egg, you'll close the whole hole. So that's exactly what's happening. It's like spread all over the hole. Then this will activate the coagulation factors now, and the fibrin clots start to form on the surface of the platelets, the activated platelets. This is where we get the phospholipids coming from. And this happens more and more until the whole hole gets closed by the activation of platelets and coagulation factors. So this is a normal platelet, and as you can see, it's a spherical shape with multiple receptors. This is glycoprotein 1A, glycoprotein 2B3A, and glycoprotein 1B. This is very important to bind to von Willebrand, very important to bind to collagen, and very important to bind to fibrinogen. All of these three receptors, they have tons of receptors, but these are the most important receptors we're going to be talking about today. At the time of adhesion, so this is, as you can see, this is binding to the collagen, which is coming from the surrounding tissue around the vessel. They will bind onto two receptors, one to the von Willebrand, which has also a site to bind to the collagen, and one from the platelets directly to the collagen. Okay? Then they'll change their shape, and they will release whatever inside their granules, which will activate the coagulation factors and form a fibrin clot or a fibrin thread between platelets. So more platelets will be formed, and this is what we call aggregation, platelet aggregation. This is what we call platelet agglutination. Okay? If you have any abnormality here, if you have any abnormal receptors or any platelet inhibition, this is not going to happen, and the patients will bleed more. Okay? Or even if the agglutination happened, but the aggregation or the activation of platelets didn't happen, then the bleed will stop a little bit and then restart again, because it's going to be a weak clot. Platelet clot only without fibrin clot, it's very weak. So that's going to rebleed again, and we'll see a lot of cases like that. This is again just another cartoon of showing the platelets, how they change their shape and how they release their granules. And they just wanted to show you that these receptors are very important, these three receptors here. Okay. So, maintaining normal hemostasis. It's very important for patients that's treated with anticoagulants or antiplatelets. We need to maintain the normal hemostasis. In order for us to do so, we usually monitor, if it's anticoag, we usually monitor it with PT-INR in case of Coumadin, or we monitor it with anti-10A in case of low molecular weight heparin. When in case of the new oral anticoagulant, there's no monitoring yet needed, or there's no methods actually to monitor it. It's very hard to monitor these new anticoagulants. In case of platelets, then the way we monitor this is by evaluating the platelet function, which is very essential in these cases, because we're putting the patients, as we saw in our case, he was on Coumadin, aspirin, and Plavix. So basically, we inhibit his coagulation factors by Coumadin, and we also inhibit platelet function by aspirin and Plavix. So we need to make sure that he is balanced. Otherwise, the patient may clot, as what happened with this patient. He clotted his third LVAD, or he may bleed. So if it's too much, he may bleed. If it's too less, he will clot, just like what we see here. So why do we need to perform platelet function testing? Just to confirm the therapy effectiveness and to avoid any bleeding or thrombotic risk, as I said. And again, why? Just because there's a wide variability between patients. Not everybody responds to the same dose, same medication equally. Okay, if I put somebody on 5 milligram warfarin, for example, other patients may need 10. If I put somebody on aspirin and Plavix, may be too much. I need to reduce the aspirin dose. Sometimes we have to stop aspirin in some cases. Sometimes we have to reduce the Plavix dose in some cases, or maybe increase the Plavix dose. So there's a lot of variations between patients, and we'll see what these variations later on. And evidence showed that in about 1 in 3 patients may not respond adequately to platelet inhibition and anti-platelet medication. 1 in 3, it's a lot. So in this case, one size cannot fit for all. Clinical impact of this management. Why do we need to know the platelet function? Because it will definitely affect the clinical outcome. It may require different medical procedures or therapies. It may increase the time that the patient spends in the hospital until we have established his platelet function before we go to surgery. And that will increase the length of stay in the hospital itself. May expose the patients for unnecessary blood product transfusion. Patient's compliance with all of these medications is very important as well. And add to this the medication cost. So as we said, one dose does not fit all. As you can see here, this is the percent of aggregation, and this is the change in response to drug percentage. And everybody is on 75 milligram daily dosing. This is, everybody got the same dose. See the aggregation, nothing, responded very well, almost normal, better than my platelets. And he's on 75 milligram Plavix. Okay, so this is showing you how much they vary between patients. The response to drug also, even when we give them very high bolus, I mean 600 milligram, this is a bolus, very high dose of Plavix, and still you can see there's a lot of variations all over the map here. Now, when we also discontinue the medication, so even if when we discontinue the medication, it will take different variations, different times in order for this for the baseline platelet function to go back to normal. See, this one like wasn't up to 90 days until you 9 days until you reach all of them for 100% for both of them, clopidogrel and prasugrel. So reasons for variations, as I said earlier, varies. There could be genetics. Could be some people has different genetics, different enzymes that's needed for the metabolisms. It's about 2 to 14%. They have less metabolizers. Could be the medication that they are getting in addition to the Plavix. For example, the PPIs, which is the anti-acidic for the gastric. And could be the conditions, whatever the health condition they have, diabetes, they have blood pressure, they have any other health condition. And the major one is non-compliance, almost 22%. This is close to 1/5 to 1/4 of your patients that they are non-compliance. And all of this gives you a significant numbers of patients that do not respond adequately, as we saw earlier, to the aspirin or to the clopidogrel. And this will be a greater risk for heart or attack or risk or clotting their LVAD system if they have any LVAD system. Right here, where it's becoming very important for us to identify or to test for the platelet functional, just to make sure that we are on the right track and our patients is balanced. And all of these anti-platelet medication, when they approved by FDA, they usually come with warning, all of them. Like in this one, I think this one's Plavix, talking about diminished activities in poor metabolizers. If somebody has any mutation in this enzyme needed for the metabolism of the Plavix, you'll have a poor response. So this is warning on the FDA approval. Another one is bleeding in Efient. If you have also patients could be exposed to bleeding or stroke if they are not compliant. The other one is bleeding risk on aspirin and Brilinta. So all of these come with black boxes or kind of like warning on their package insert. We already know about this. Clinical scenario that you may need platelet function varies. Most common is traumatic brain injury in patients about more than 65 years of age. Brain stenting, if somebody has a stent in his brain veins, that also need to be monitored very well because it's very high risky. Cardiac stents also. Surgery, regardless if it's trauma or if it's elective, if it's an emergency surgery or if it's elective surgery. And usually if somebody is on any of these medication, usually it delayed the procedure. And sometimes up to 5 to 7 days until it weaned by itself, until it's clean from the system by itself. In order to avoid this, if we have to take him to the surgery, if it's an emergent, then a lot of blood products will be given for this patient to reverse the function of these medications. So how can we do it? How can we test for platelet function? In our lab, we do have platelet aggregation. I'm not sure if you guys know the platelet aggregation. It's a very nice, very useful test. 4 to 5 hours probably to get the answer. You need fresh samples. You need a tick sitting there for 4 to 5 hours versus 10 minutes. Okay? Similar, almost exactly same results. Not going to be that much different. We didn't see any difference between them. So the point of care testing from VerifyNow actually helps in identifying the anti-platelet function. And it's a rapid assay to perform. As we're going to see later on, it's going to be like within 5 to 10 minutes. Yes, sometimes you have to incubate these samples, but still, even with incubation, still much more significant time than waiting 4 to 5 hours. And if you're going to do a regular platelet function, regular platelet aggregation for somebody sitting in the hospital, are you going to repeat this every day or every other day just to see where the patient's going? That's going to be a lot of work. So how does VerifyNow works? VerifyNow, it's kind of like beads. These are kind of beads covered by fibrinogen. And these beads you'll expose to the blood samples, and according to whatever the patient is on, you'll see the inhibition. It will bind to the specific code, to the fibrinogen on these beads. And binding, as we're going to see later, binding will let the light go through more. So it will be much more clearer for the light to go through. So that will tell you that the inhibition is very high. If there's no binding, the inhibition is very low. We'll see that later in a different slide. It can test for aspirin, for GB2B3 inhibitors, or for the Plavix, which is the B2Y12 inhibitors as well. Now, the way we test for VerifyNow, or the way we manage the platelet function, is by measuring the PRU test, which is the B2Y12 reaction units. And for each medication, we have a special PRU. This one, I think it's for Plavix, as you can see. So if the numbers of the PRU came between 10 to 120, there's the drug effect. So it's really, there's a decreased platelet reactivity. So the drug is working very well. This is a gray zone in between. If between 220 to 380, basically there's no inhibition. So that we were able to get the platelet back to normal function by cleaning the effect of this medication, or the patient is not taking his medication to start with. This is in acute coronary syndrome patients. As you can see, the PRU for off-drug versus on-drug. And you can see the difference here between the close to 280 here, or 260, 270, versus the 150 here. So these on drug versus no drug. So this is a lot of drug effect versus no drug effect. But again, still see this group here in between. You can't tell where's your patient's from. This is again due to variations in the response. So that's why it's really needed for each patient. There's no one dose can fit for all. VerifyNow system includes the instrument, 3 different single-use test devices. The electronic quality control also comes with the reagent, with the instrument, and the wet quality control. And I'll let Mark at the end can talk about all of these in details if somebody is interested. Proficiency testing supported by both CAB and API. How does it work? So it's very easy. As you can see at the end here, you can come up and see it yourself if you want to try it. You open the cover, you put the cartridge in, and you just insert your whole blood sample. And as I said, as we're going to see later on in the next couple of slides, there's a table telling you about the incubation time. So in case of aspirin, I think it's the longest one, maybe half an hour. The others usually like 10 minutes or 20 minutes. We'll see it later. You insert the tube upside down, and you just close this and wait 2 to 5 minutes to get the answer. It will give you the PRU. The PRU been validated with a lot of clinical studies to show you if there's any reactivity still there or not. Okay, so it's a patient's coming for a cath lab, for example. Is the physician's going to put the cath before he knows what the platelet function remained in this platelet? No, he's going to wait until you get him the PRU on this patient. So, and so similar for any urgent surgeries as well. The mechanism of action, so this is what I talked about. So this is the cartridge you put in, and you flip the tube, you put it in here, the blood will go through, will suck inside, and inside there is the beads that's covered with the collagen. I'm sorry, fibrinogen. Okay, now you expose the blood, the blood will come through it, and if the platelets are inhibited, then these receptors we saw at the beginning, they're not going to be functional, so they're not going to bind to the fibrinogen. Okay, when they don't bind to the fibrinogen, it's going to be so cloudy in there, and the light won't go through. If the light won't go through, then that means the platelets are very active. Okay, so the platelets are very functional. So the drug is working. That's what it means. My drug, the dose I'm giving to my patients, the drug is working. Okay, my patient is not taking his drug, or we did stop it early enough. Now my platelets is not inhibited. It's gonna bind to the speeds, make it more clear to the light to go through. Exactly same principle of the platelet aggregation that we use on Helena device, or just like the regular PRP aggregation. Very, very similar principle. It depends on the light, how go through, clear versus cloudy background. So when they bind here to the fibrinogen, then you can see that there's basically the drug is not working. Either my patient is not taking the drug, or my patient has some sensitivity to the drug, or whatever. Could be a lot of other reasons. This is basically all what I did say over here. This is kind of like a table to show you all the differences between the different reagents or different antiplatelet. So if you're testing the the P2Y12 receptors, which is basically Plavix, Eviant, or Brilinta, versus aspirin or Repro and Integron, it's just telling you how much depends on the dose you're given and how long the suggested test timing should be. So if you're just giving the regular dose, which is more than 80% to 85% of patients are on 75 milligram, you need at least about more 7 days to be on maintenance. With 8 hours or 6 hours, it depends on the other doses. Okay. For Eviant also, it will show you all the minute needed to identify the platelet function. With aspirin, it's about 2 hours. Once you give them the aspirin, the dose within 2 hours, you can tell if it's working or not. And similar for the 2B3A. Incubation, as I said, could be 10 minutes. With aspirin, it's about 30 minutes. But with Plavix or any P2Y12 inhibitors, it's only 10 minutes. And this is the time when you put the tube in the instrument. It's about 3 to 5 minutes, as you can see here, or less than even 2 minutes in the repro. So back to our case. I'm just going to tell you, just to remind you about it. So it's about a 66-year-old who came the third time for his clot and his LVAD. He was admitted to the hospital because of the discomfort and chest pain, shortness of breath. It seems like he clotted his third one, and he has a very good back history of clotting. Basically, this patient ended up non-compliant. He wasn't taking his medications, causing him trouble in his stomach, so he decided to stop on his own. And every time come back to the hospital, causing the hospital close to 150,000 between ICU, ECMO, and changing the LVAD. This is what I know could be even much more expensive than this. So patient was on 81 milligram of aspirin. That's he decided to stop, and was on 75 milligram Plavix. That's he decided to take it every other day. He's treating himself. I'm sure he was taking commitment. His INR was abnormal. So patients went for his fourth LVAD, and he after surgery he was anticoagulated on anti-platelet therapy, and we have to give him IV Repro because he has so active platelets. His platelets was very active, and we couldn't even inhibit them with very high dose of Plavix and aspirin. We were sure that we're going to cause this guy an ulcer with the amount of aspirin that we were giving him. So we have to give him IV platelet inhibitor, the GB2B3A. But again, we have to discharge him. He was in the hospital for almost 3 weeks. We have to discharge him, so we have to stop the IV Repro. And every time we stop the IV Repro, we did platelet mapping on him using TAG. His platelet mapping go back again and tell us that he's gonna clot soon. We go back again and put him on it until we finally decide to put him on multiple B2Y12, 2B2Y12 medication, and we told him, if you're gonna stop it this time, try not to come back. As I said, we monitored him through the platelet mapping on TAG. It did help us a lot because in platelet mapping, it's show you how percentage is related to the coagulation factors versus what the percentage of the clot related to the platelet function. So it did help us a lot in identifying the right dosage. He was discharged on 325, 75 milligram Plavix aspirin, and 15 milligram warfarin. We give it to him twice per day, as I said, instead of two times. I'm sorry, it was twice per day. And the follow-up monitoring was advised to be on every 3 days for the first couple of weeks, just to make sure that he's compliant with his medication. And we make sure that his wife is going to be now giving him the medication instead of himself taking it. Yeah, we can't trust him anymore. And then I think we followed him for like on a weekly basis for the next 3 to 4 weeks, and he was still doing good. Up until this morning, he's not back yet. I'm not sure what's going to happen. Yes. That's it. I think that's all what I have.